is V7. It's hyperthyroidism. A 29-year-old woman presents in your clinic with a neck swelling and a history of weight loss and sweating. What do you do? Sound like hyperthyroidism. I would first take a history. How long has she had the neck swelling? And symptoms of hyperthyroidism including heat intolerance, weight loss, fatigue, sweating, palpitations, anxiety, diarrhea, menstrual periods. And I would also then examine her, confirm that the neck swelling is a goiter, and feel for the dominant nodules. Listen for a bruit. Look for systemic signs of hyperthyroidism, including tachycardia, brisk reflexes, tremor, acropathy, pretibial myxedema. Look for thyroid eye signs in the Graves disease, exophthalmos, lid lag, lid retraction, red conjunctiva, and squint and diplopia. Likely diagnosis given her age is the Graves disease, but I would also want to exclude the toxic multinodular goiter, malignancy, subacute thyroiditis, and ovarian or pituitary tumor. She has a diffuse goiter and bilateral exophthalmos. You suspect Graves disease. How would you confirm this? So blood tests like TSH will be low, free T3, T4 will be raised, and immunoglobulin antibodies, IgG antibody to TSH receptors. Neck ultrasound and radiograph scan to look for a hot nodule, a toxic nodule goiter, or signs of malignancy. Blood test confirm Graves disease. Blood tests confirm Graves disease. How will you treat her? Because she has eye signs, radioiodine is not an option. I would discuss with her the pros and cons of medical treatment versus surgery, but surgery would be my treatment of choice. I would offer her a total thyroidectomy. A recent Cochrane review has concluded that total thyroidectomy is superior than a subtotal thyroidectomy. So she does not want to have surgery because she's 12 weeks pregnant. How will you treat her? I would give her propyl antithyroid drugs, that are the propyl thiazole. It is safe in pregnancy, not the carbimazole. It's contraindicated in the pregnancy. It inhibits the thyroid peroxidase and reduces the T3, T4 synthesis. It works rapidly and there are no permanent side effects, but there is a risk of relapse. वर्क फिनिश करो और लाइट बंद भी नहीं किया आपने. She comes to see you in 1 year's time, having had a relapse and is thyrotoxicosis. She wants to consider surgery. Are there any precaution you need to? Obviously, she is hyperthyroid and she is an antithyroid drug, so we have to make her euthyroid. So we need to check her blood levels again. So I would also give her propranolol, which will improve the symptom of thyrotoxicosis and inhibits the peripheral conversion of T3 to T4. This must be continued for 5 to 10 days post-operatively as well, because of how long half-life of the circulating T4. I would ask her to take Lugol's iodine 7 to 10 days before surgery to reduce vascularity of the thyroid and make the gland firmer. This is called Wolff-Chaikoff effect. The reduction in the thyroid hormone levels induced by the injection of supraphysiological doses of iodine is known as. The mechanism is via the prevention of organification in the thyroid gland, cessation of thyroid hormone synthesis, and decrease in the levels of the preformed thyroid hormone. The effect occurs within 24 hours and is maximum at 10 days. The patient should also be informed about potential risks associated with the total thyroidectomy, including recurrent laryngeal nerve, superior laryngeal nerve, hypothyroidism, or hypocalcemia. And the most recent audit from the British Association of Endocrine and Thyroid Surgeons said that post-op hypocalcemia is higher in the total thyroidectomy than the Graves disease, than the MNG, and this may be due to the increased technical difficulty in identification and preservation of the parathyroid gland due to the inflammatory process. I would tell her that she needs to take thyroxine for the life problem. How would a thyroid storm present and how would you treat it? So this is a life-threatening condition initiated by the physiological stress like surgery, or it can be flared up by pregnancy, childbirth, or infection. The mortality is 10%. Patient develops fever, tachycardia, hyperthermia, diarrhea, jaundice, and change in their mental status ranging from delirium to the coma. The Borch-Wartov-Sky scoring system can be used for diagnosis. The scoring system takes into account the severity of symptom multiple organ decompensation, including thermoregulatory dysfunction, tachycardia, atrial fibrillation, disturbance of consciousness, congestive heart failure, and gastrohepatic dysfunction, in addition to the role of precipitating factors. So scores more than 40 are indicative of thyroid storm. Scores between 25 to 45 are also thyroid storm. and less than 25 unlikely thyroid storm. So these are treated on the ITU. The goals of treatment are lower the circulating thyroid hormone by preventing TH synthesis and blocking TH release, antithyroid medication like propylthiouracil to block the peripheral effect of TSH, beta blockers and glucocorticoids, supportive care for systematic decomposition, IV fluids, sedatives, coolings, blankets. They may need intubation. Treatment of underlying precipitating event. Thank you.